Sure. So the members of the ACR Guideline Committee performed several tasks to help develop the 2024 ACR guidelines for managing lupus nephritis. So this included drafting PICO questions, performing a systematic literature review for those questions, and then grading the quality of evidence. Recommendations that were created were then also voted on by an expert voting panel. And the grade methodology provides a tool to help rate the quality of evidence of the guidelines. The majority of recommendations were conditional, which means there was uncertainty regarding their benefit or low quality evidence, or that the committee felt the recommendations should be more sensitive to patient preferences. On the other hand, some were strong recommendations, meaning the panel was confident that the benefits of that particular intervention or recommendation, those benefits outweighed any potential harm. So the American College of Radiology last published lupus nephritis guidelines in 2012, and at this time, the recommendations were induction therapy, so high-dose glucocorticoids plus either cyclophosphamide or mycophenolate mofetil, followed by a mycophenolic acid agent for maintenance therapy. Since that time, there have been additional agents that have been approved for lupus nephritis, such as belimumab and voclosporin. And so these new ACR guidelines emphasize the use of triple therapy. And this introduction of the triple therapy has sort of blurred the distinction that we used to have between induction therapy followed by maintenance therapy, because we know the early introduction of multiple combination therapy has been shown to rapidly reduce disease activity. And so this is why early introduction of combination triple therapy is emphasized in these new guidelines. The new ACR guidelines emphasize a sort of base treatment or therapy for all patients of hydroxychloroquine plus renin-angiotensin aldosterone inhibitors, so things like ACE inhibitors or ARB therapy in all patients. Then for class 3, 4, plus or minus 5, the recommendations are for triple therapy with steroids and mycophenolate or with belimumab or calcineurin inhibitor. An alternative triple therapy is to use cyclophosphamide. So in this combination, you would use steroids, then cyclophosphamide followed by MMF maintenance and belimumab as the three components of triple therapy. And then for class 5, lupus nephritis for patients with more than 1 gram of proteinuria, these guidelines recommend to also use triple therapy, but specifically with steroids, mycophenolate, and a calcineurin inhibitor. For those with class 5 with less than 1 gram of proteinuria, treatment can be steroids and or additional immunosuppression, which includes the MPA analogs or azathioprine or a calcineurin inhibitor. The guidelines also recommend use of pulse dose IV glucocorticoids, just like we've traditionally done in rheumatology. So methylprednisolone, 250 to 1,000 milligrams IV once daily for 1 to 3 days. However, the guidelines recommend a much lower dose of initial oral prednisone after the pulse, so 0.5 mg per kg per day or a maximum of 40 milligrams per day. And this is much less than what we traditionally use as rheumatologists in treating lupus nephritis, often starting at 1 mg per kg of oral prednisone after the pulse. They also recommend treatment with triple therapy based on RCTD data that triple therapy has improved outcomes compared to dual therapy. And they recommend using some form of immunosuppression for 3 to 5 years, given studies have shown that there's persistent disease activity on repeat kidney biopsy for years following an initial lupus nephritis diagnosis. So it's definitely important to consider individual patient characteristics. There's a lot of heterogeneity in how lupus presents and how we think about managing these particular patients. So in the guidelines, they actually comment, the fact that there's randomized clinical trial data that shows a similar response rate comparing a mycophenolate-based regimen to cyclophosphamide. But the voting panel favored mycophenolic acid analogs in their triple therapy options, and they cite a few reasons for this. So better toxicity, reduced risk of malignancy, and then a lower impact on fertility with the mycophenolic acid based regimens over cyclophosphamide. But they highlight some instances where, we may opt for IV cyclophosphamide instead. So someone with more severe disease, a patient with non-adherence, intolerance to some of the oral regimens. And so one example, if a patient has rapidly progressive glomerulonephritis with advanced disease, so lots of crescents, fibrinoid necrosis on biopsy with rapidly declining kidney function, we may opt for cyclophosphamide as one of the components of the triple therapy over a mycophenolate-based regimen. So patients with lupus often have very complex medication regimens and symptom burdens. So I think some challenges of incorporating these guidelines will be thinking about their pill burden, such as, patient tolerance, as well as ability to take all of these medications, thinking about medication adherence. So for example, a regimen that contains the mycophenolic acid analog as well as a calcineurin inhibitor as part of triple therapy would be 12 tablets just for those two medications alone, per day. That's not including the tablets for hydroxychloroquine, prednisone, and the ACE or ARB inhibitor. And so managing lupus nephritis requires significant, complex, medication regimens and significant health literacy and numeracy on the patient side to manage these complex drug regimens that are fluctuating over time as we, you know, taper glucocorticoids and try to up titrate some of the initial therapy. But I think these guidelines offer some central changes in how we approach our treatment to lupus nephritis, with some key points to remember is the lower initial doses of oral prednisone following the IV pulse. So 0.5 mg per kg of oral prednisone or a max of 40 milligrams per day. And then two, the use of triple therapy over dual therapy for most circumstances and for all patients with class 3 or 4 lupus nephritis.